Penicillin. Penicillin was the first antibiotic developed and used clinically. It was discovered accidentally by Alexander Fleming. The source of penicillin is high-yielding Penicillium chrysogenum. Mechanism of action. Beta-lactam antibiotics produced bactericidal effect by inhibiting cell wall synthesis in susceptible bacteria. Bacterial cell wall is composed of peptidoglycan. Peptidoglycan has glycan chain cross-linked by peptide chain. The glycan chain is composed of alternating amino sugar, N-acylmuramic acid and N-acylglucosamine. A pentapeptide linked to N-acylmuramic acid has a pentaglycine attached to it. This pentaglycine is cross-linked with the pentapeptide of adjacent strand. Transpeptidase causes cross-linking between the pentaglycine residue of one strand and fourth amino acid of adjacent pentapeptide by cleavage of the terminal D-aniline. The cross-linking makes the cell wall rigid and stable. Beta-lactams, the structural analog of D-aniline, inhibit transpeptidase, thus inhibiting cross-linking of peptidoglycan and cell wall synthesis. Cell wall deficient forms are produced which undergo lysis. Beta-lactams exert their cidal effect when the bacteria is actively multiplying and synthesizing cell wall. Penicillin binding protein consisting of transpeptidase. Other enzymes are related. Proteins are located in the cell membrane of bacteria. The cell wall in the gram-positive bacteria is composed mainly of highly cross-linked peptidoglycan, which is 50 to 100 layer thick and is near the cell surface. Gram-negative bacteria, the peptidoglycan layer is only 1 to 2 molecules thick. In addition, there is an outer lipopolysaccharide layer, hence gram-negative organisms are less susceptible to penicillin than gram-positive bacteria. Mechanism of bacterial resistance to penicillin. Bacteria develop resistance first by producing beta-lactamases which destroy the beta-lactam ring, example S. aureus, E. coli, gonococci, Haemophilus influenza, etc. Second, due to altered penicillin binding protein which have less affinity for beta-lactams, for example, S. pneumoniae. Third, due to decreased ability of the drugs to penetrate to its site of action. Pharmacokinetics. Most of the orally administered penicillin G is destroyed by gastric acid. Hence, penicillin G is usually given by intravenous route. It can also be administered by intramuscular route but is painful. Penicillin G is widely distributed in body tissue but poorly crosses blood-brain barrier. Although penicillin although during meningitis adequate amount reaches to CSF, penicillin G is rapidly excreted in urine mainly by active tubular secretion since renal function is not completely developed in infants and neonates. Excretion of penicillin is slow. The action of penicillin can be augmented and prolonged by giving probenecid simultaneously. Preparation of penicillin G. The duration of action of penicillin G is increased by combining it with poorly water-soluble compounds such as procaine or benzathine to yield aqueous suspension. They are called repository or depot penicillins. Adverse effect of penicillin. Penicillin are relatively safe. They may cause hypersensitivity reaction such as skin rashes, fever, dermatitis, bronchospasm, angioedema, joint pain, serum sickness, or anaphylactic reaction. The major manifestation of anaphylactic shock are severe hypertension, bronchospasm, and laryngeal edema. It is an IgE mediated immediate type of hypersensitivity reaction. It is not a dose related adverse drug reaction and can occur with any dosage form of penicillin. Cross reactivity can occur among penicillins and also among beta lactam antibiotics. Treatment of anaphylactic shock. Adrenaline 0.3 to 0.5 ml of 1 ratio 1000 solution intramuscularly. Hydrocortisone 200 mg intravenously. Diphenhydramine 50 to 100 mg intravenously or intramuscularly. Precautions. Before giving penicillin, history of previous administration and allergic manifestation, if any, must be noted. Second, patient with history of asthma, allergic rhinitis, hay fever, etc. There is an increased risk of penicillin allergy, hence it should be avoided in such cases. Third, sensitivity test should be performed by an intradermal test on the ventral aspect of forearms. Itching, erythema, or wheal formation are watched for. A negative test does done for not ensure absolute safety. Fourth, injection adrenaline and hydrocortisone should be kept ready before injecting penicillin to treat the anaphylactic reaction. Other adverse effects of penicillin are pain and sterile abscess at the site of intramuscular injection. Prolonged use of intravenous penicillin G may cause thrombophlebitis. Jaris-Hersheimer reaction. It is an acute exacerbation of signs and symptoms of syphilis during penicillin, thereby due to release of endotoxin from the dead organism. The manifestations are fever, chill, myalgia, hypotension, circulatory collapse, etc. It is treated with aspirin and corticosteroids. Therapeutic uses. Owing to the risk of anaphylaxis as well as availability of the better antimicrobial agents, the use of penicillin G has declined. First, pneumococcal infection. In pneumonia, meningitis, or other serious infection, third generation cephalosporin are the drug of choice. However, intravenous penicillin G can be used as an alternative if the organism is sensitive. It should be continued for 7 to 10 days. Second, streptococcal infection. Penicillin G is useful for the treatment of streptococcal pharyngitis, otitis media, rheumatic fever, etc. Procaine penicillin G 6 lakh unit intramuscular once daily for 10 days or benzathine penicillin G 12 lakh unit intramuscular as a single dose are used for the treatment of rheumatic fever. Third, meningococcal meningitis. Third generation cephalosporin are preferred. Intravenous penicillin G is also effective. It is not ultimate eliminate carrier state. Rifampicin attains high concentration of nasopharynx and eliminates the meningococcal carrier state. Hence, rifampicin, not penicillin G, is used for prophylaxis of meningitis. Fourth, gonococcal infection. Penicillin was the drug of choice for gonococcal infection because of the emergence of resistant organisms. Penicillin are not preferred at present. Third generation cephalosporins, cefixime are the drug of choice for uncomplicated gonococcal infection. Fifth, syphilis. Penicillin G is the drug of choice for syphilis. T. palladium is very sensitive to penicillin and is killed at very low concentration of the drug. The alternative drugs are ceftriaxone, azithromycin, and doxycycline. Penicillin is the drug of choice for treatment of syphilis in pregnancy. 6. Diphtheria. It is an acute infection of the upper respiratory tract causes C. diphtheriae. It is treated mainly with a specific antitoxin. Penicillin G helps to eliminate carrier state. Patients allergic to penicillin are treated with erythromycin. 7th, Clostridial infection. The main treatment is neutralization of the toxin by using human tetanus immunoglobulin. For gas gangrene, penicillin G is used as an adjunct to antitoxin. 8th, other infection, anthrax, listeria infection, Lyme disease, leptospirosis, actinomycosis, rat bite fever, etc., are effectively treated with penicillin G. Ninth, anaerobic infections. Penicillin G is effective for the treatment of anaerobic infections. Prophylactic uses of penicillins. Rheumatic fever. The causative organism is group A beta hemolytic streptococcus. For rheumatic fever prophylaxis, benzathine penicillin G is the ideal agent. It is given in the dose of 1.2 million unit intramuscular once a month and continued for life in high risk people. Patients allergic to penicillin are treated with erythromycin and sulfadiazine. Ultimation or drawbacks of penicillin G. First, acid labile, orally not very effective. Second, short duration of action. Third, narrow spectrum of antibacterial activity. Fourth, destroyed by penicillinase enzyme. Fifth, possibilities of anaphylaxis. To overcome most of the above drawbacks, semi-synthetic penicillin have been developed. Classification of penicillin with their spectrum of activity. Penicillin are divided into natural penicillin and semisynthetic penicillin. Natural penicillins contain penicillin G, procaine penicillin G, benzathine penicillin G. Penicillin G is given intravenous and intramuscular. Procaine penicillin G is given intramuscular and benzathine penicillin is given intramuscular. Penicillin G is susceptible and antimicrobial spectrum uses of natural penicillins are Streptococcus species, Neisseria gonorrhea, Neisseria meningitidis, beta anthracis, Corynebacterium diphtheria, Clostridium spirochetes, Trypanoma, Leptospira, Actinomyces and most of the anaerobes. Semisynthetic penicillin. First, acid-resistant penicillin, phenoxymethyl penicillin. It is given orally. It is susceptible. Antimicrobial spectrum are similar to penicillin G, attains very low plasma concentration, hence used only for mild streptococcal and pneumococcal infection. Second, penicillinase resistant. Penicillins, methicillins, oxacillin, cloxacillin, dicloxacillin. In this, methicillin is given intramuscular and intravenous, whereas oxacillin, cycloxacillin, dicloxacillin are given oral, intramuscular as well as intravenous. They are resistant and their antimicrobial spectrum are they are sensitive strain of Staphylococcus aureus and S. epidermis infection. Third, extended spectrum penicillins are aminopenicillins, ampicillin, amoxicillin. Ampicillin, amoxicillin are given orally, intramuscular and intravenous. They are susceptible. Antimicrobial spectrum are antimicrobial spectrum extended to gram-negative bacilli, Escherichia coli, Proteus, Salmonella, Shigella, Haemophilus influenza, and Helicobacter pylori. Of all the oral beta-lactams, amoxicillin is the most active agent against both penicillin sensitive and penicillin resistant Streptococcus pneumoniae. Ampicillin is the highly effective against Listeria monocytogenes. Carboxypenicillins, carbanicillins, carbanicillin indanyl, ticarcillin. Carbanicillin is given intramuscular as well as intravenous, and carbanicillin indanyl is given orally, and they are susceptible. Their uses are in infection caused by Pseudomonas aeruginosa and Proteus uridopenicillin, meslocillin, piperacillin. Piperacillin is given intramuscular and intravenous. They are susceptible and their uses in Pseudomonas aeruginosa, Klebsiella, and Enterobacteriaceae infection. Therapeutic uses of aminopenicillins. First, upper respiratory tract infections. Ampicillin and amoxicillin are effective for pharyngitis, sinusitis, otitis media, bronchitis, etc., caused by S. pyogenes, S. pneumoniae, and Haemophilus influenza. Among oral beta-lactamase, amoxicillin is the most effective agent against penicillin-sensitive and penicillin-resistant S. pneumoniae. Second, urinary tract infection. Fluoroquinolones are the preferred antimicrobial agents for urinary tract infection. Ampicillin can be used if organism is sensitive. Third, meningitis. At present, third generation cephalosporins along with vancomycin are the drug of choice for treatment of meningitis caused by S. pneumoniae and S. meningitis, as the organism have developed resistance to ampicillin, but ampicillin is very effective for meningitis due to listeria. Hence, the combination of ampicillin, vancomycin, and third generation cephalosporin is used for empirical therapy of bacterial meningitis. Fourth, bacillary dysentery. Fluoroquinolones are the drugs of choice. Some cases may respond to ampicillin, but many strains may have developed resistance to it. Fifth, subacute bacterial endocarditis. Aminopenicillin is combination with gentamicin have been used for treatment of subacute bacterial endocarditis. Amoxicillin is the most commonly used AMA for prophylaxis of bacterial endocarditis. Sixth, typhoid fever. A fluoroquinolone or ceftriaxone is the drug of choice for typhoid ampicillin. Quatrimoxazole or ciprofloxacin are used for eradicating carrier state. Adverse effect of aminopenicillin and drug interaction. The adverse effects of penicillin are similar to those penicillin G, but skin rashes and diarrhea are more common. Probenecid compete with beta-lactamase for active tubular secretion and regards their excretion, thereby increases the plasma concentration as well as duration of action of beta-lactamase. Hence, simultaneous administration of probenecid and penicillin is useful for the treatment of bacterial endocarditis and gonococcal infection to enhance the therapeutic efficacy of beta-lactamase. Other penicillins. They are carbanicillin, indenyl, tica, ticracillin, mesolacillin, and piperacillin. Uses: serious infection, bacteremias, pneumonias, UTI, burns, etc. By P. aeruginosa and Proteus are more effectively treated with piperacillin than carbamazepine. Carbamazepine indenyl is used orally for the treatment of UTI caused by P. aeruginosa and Proteus. T- Ticracillin is used in combination with beta-lactamase inhibitors and aminoglycosides for the treatment of mixed nosocomial infection. Adverse effect. They are similar to penicillin G. Congestive cardiac failure may be precipitated due to sodium content of carbamazepine sodium. It can also interfere with platelet function and cause bleeding. Beta lactamase inhibitors. They are carbonic acid, sulbactam, and tazobactam. They structurally resemble beta lactam molecules. Beta lactamase inhibitors bind to beta lactamases and inactivate them. Co administration of these drugs with beta lactams increases the activity of beta lactams by preventing them from enzymatic destruction. Galvanic acid. It is isolated from streptomycin calvogerus. It competitively and irreversibly inhibits beta-lactamases produced by a wide range of gram-positive and gram-negative bacteria. After binding to the enzyme, galvanic acid itself gets inactivated, hence called suicide inhibitors. Thank you.